So welcome to the first WBUR CitySpace virtual town hall. And thank you for joining us and for joining each other. I'm Carey Goldberg. I cover health and medicine and science at WBUR, and I edit the Common Health section on WBUR.org, where you'll find most of our COVID-19 coverage online these days. I think I speak for the entire staff of WBUR when I say, we hope we're helping you. This is a very harrowing time for just about everybody, and we're all doing our best to bring you reliable information, even when so much remains unknown. And maybe to even make the time in captivity at home a little more tolerable with some familiar, calm voices and a never-ending stream of enlightening stories. On a sort of personal, professional note, we're all living in this surreal new reality, but journalistically, this new reality is a story that we are doing our best to cover, to tell you what you need to know. And I think I can say, after more than 30 years as a journalist, including at the New York Times, it's the most momentous story I've ever worked on. It's a once in a lifetime event. And the only comparison I can make is when I helped cover the collapse of the Soviet Union way back in 1991, because it was a superpower bristling with nuclear weapons, and it really did seem like the fate of the whole world might hang in the balance. And what I most remember about trying to cover that was the feeling of fog, like the fog of war, this feeling of groping to try to figure out what was happening and what would happen next, but barely being able to because nothing was normal. And I describe trying to cover COVID-19 as feeling similar, but also fundamentally different. The dominant feeling is of a fire hose spewing information on all different platforms and from all different sources. And half the challenge is trying to make sense of that, while the other half of the challenge is feeling like, even with all the journalistic resources we have being thrown at this story, there's still not enough to begin to do it justice, because this pandemic is affecting every single sphere and every single person in ways that all matter. A bit more on the personal side, I work with a superb health coverage team at WBUR. Our editor, Elizabeth Harrison, says this story is unlike any other because we're all living it in our own homes and families, even as we cover it. And the incomparable Martha Biebinger said, not to get all fundraisy on you, but the community has invested in WBUR, and that's allowing us to be a vital news source now. So much of journalism, especially newspapers, has been decimated. You can't look in the local Brockton paper for what's happening at the local hospital anymore. And the also incomparable Deborah Becker says she's seeing so many people in our newsroom working practically around the clock to cover this torrent of news. And I'm here to tell you that she's one of them. She says it's particularly strange for her to have to cover a story without going to the scene. We're not allowed to go hardly anywhere. We're just not sure it's safe. And she says it's tough for her to stop working. Many days she looks up and realizes it's dark, and she's been on her computer since early morning. I think she really misses all the big clocks in the station that we're not going to these days. And our newest team member, the very talented Angus Chen, says that what's most striking to him is how global this all is. He was in touch recently with someone locked down in Brunei, and how it connects all humanity in a way that he finds sad, but also beautiful. So thank you for being here. Thank you for listening. I think we had more than 700 registrations for this event. So we can't all see each other, but we are all here together in some weird 2020 way. And I'd like to apologize that we only have an hour, and people sent in dozens and dozens of questions, way more than we have time for. So if you don't hear your question, I'm sorry. Also, some of the questions were similar, so your question might have been consolidated into another one. The top criterion we used for selecting questions was whether they best fit the expertise of the guest expert I'm so pleased to introduce to you, Dr. Shira Doron, an infectious disease physician and the hospital epidemiologist at Tufts Medical Center. And Dr. Doron, first and foremost, thank you for your service and for your courage, not only to work in a hospital during this pandemic, but also to face a live audience of several hundred people in the midst of all of this. And
thanks for having me.
It's great to have you. I'd like to start by asking you to explain to the audience just what you do, what your experience has been these past few months, including maybe what keeps you up at night and what inspires you to keep going.
Well, first and foremost, I'm an infectious disease physician, and I take care of patients with complicated infections. But my main role at the hospital is that of hospital epidemiologist. And put simply, that means that my job is to keep patients, staff, and visitors safe from infection while in the hospital. So during normal times, I focus on things like device-associated infections, for example, the urinary tract infections patients get from having catheters, or antibiotic-resistant infections like MRSA, MRSA. An occasional sleepless night is not uncommon for me, but usually I'm worrying over what appears to be a higher rate of hospital-acquired infections in patients that month, or maybe that the Ebola situation is heating up in Africa, and I'm wondering if we should retrain staff on how to manage that again. And while my job includes pandemic preparedness, and I've spent many years planning for a respiratory virus pandemic, I have to admit that I never in my wildest dreams imagined it would be like this. The drain on medical supplies due to the virus hitting the entire world virtually all at once, that's the number one thing that keeps me up at night. We're so low on supplies, and because it's my job in normal times to teach people what PPE, personal protective equipment, to use for which patients and for how long, I just find myself in an impossible situation. But I remain inspired by the bravery, professionalism, competence, and innovation that I see in my colleagues every day.
Thank you. Beautiful. So let me ask you first, what are you seeing at Tufts Medical Center these days? What are you hearing from colleagues at other institutions? We got the latest numbers from the state, and it looks like the ICU patients at Tufts Medical Center jumped over a couple of days from about 19 to I think 34. So those are on the rise. What's happening? Is the surge here? What's going on?
So the number of COVID cases and specifically COVID hospitalizations in Massachusetts are continuing to rise. Many hospitals have reached or are getting very close to what they would consider to be their capacity. As a tertiary care hospital, which generally gets a substantial proportion of its admissions as transfers from other hospitals, and because no one is yet an expert in COVID care, we were really slower to fill than some of our neighboring institutions and our community affiliates. But once they filled up, our admissions started going up quickly because we started taking those transfers. So we have double the number of COVID cases that we had last week, and significantly more than we had yesterday. We're placing critical care patients in areas normally used for non-critical patients. We have adults being managed in the pediatric ICU by our amazing pediatric intensive care docs.
Wow. And the statewide figures are, I think the last I saw, we're at about 60% capacity. So like it's this feeling that there's still capacity left, but I'm wondering if you are watching internally what you're expecting in the next few days.
Yeah, I mean, we have capacity. As I said, we've moved into contingency sort of areas, but we are in the surge. And with the numbers still rising, at least from where I sit, we've not yet peaked. So the question of whether the system will become overwhelmed, whether we'll have enough ventilators, whether we'll have to make those horrible decisions that we hope to never have to make, like who gets a ventilator and who doesn't, that has yet to be answered. And we've had more time to prepare than Italy and than New York. We have the Boston Convention and Exhibition Center open and the DCU open in Worcester, and those are pop-off valves taking patients those are open now before we even need them, already taking patients before we're at capacity. The state has been receiving more ventilators. We're as prepared as we can be, but as I said, certain supplies are running dry, and that puts our healthcare workforce and patients in danger.
Which supplies are you referring to?
PPE, supplies that you need for critical patients like IV tubing, for example, certain medications.
Mhm. Wow. And how about Boston, Massachusetts? We're generally fourth, I think, in terms of the number of cases. How do you see the statewide picture at this point, like the present and the immediate future?
Yeah, I would not say that as far as hospitalizations or deaths that we're seeing a flattening yet. So we are still on the rise, and we are still bracing ourselves for more.
And for the longer term future, there was a really very depressing paper in the journal Science today that came out from epidemiologists at the Harvard Chan School of Public Health. They're predicting that given the dynamics that we've seen so far of COVID-19 transmission, we'll probably need social distancing on and off intermittently, at least through 2022, which made me curse quite a bit when I read that. What do you think of that?
I do worry that a lot of people, including sometimes myself, are putting all their faith in a vaccine as the way to get back to normal. You know, vaccines typically take at least 10 years to bring to market, and 90% of candidates fail for one reason or another. And though we've been told that the process is being fast-tracked, I fear that we may be being overly optimistic. This virus is probably here to stay, and what exactly that looks like in terms of our personal freedoms over the next few years is really anyone's guess at this point.
Okay, let's move from the big picture to the very small personal one. We got a lot of questions for you about disinfecting groceries. There was a great one about whether it's okay to have sex with your partner if you've been shut in for 4 weeks and neither one of you is sick. What, on the personal level, what are you doing for virus avoidance?
Well, I leave my shoes at the door. I clean my hands a lot. I wipe my phone with disinfectant, not necessarily every day. I don't clean the mail or the grocery bags or the outside of the takeout containers, but I do clean my hands often as I handle those things. I try not to touch door handles or elevator buttons. And if I do, I definitely don't touch my face until I've cleaned my hands. And I try not to let the worry over the disease consume me. I've got enough to worry about here at the hospital.
So just to follow up, why don't you disinfect the grocery bags or the mail? I mean, there was this paper that came out suggesting that the virus can survive on surfaces for a day or two.
It can. And I think everyone's got to find their own balance of being obsessive and, being a little bit less so. I clean my hands and I try not to touch my face. And so if I've touched the grocery bags, but I've cleaned my hands, then that should do it.
That makes sense. Okay, moving on to questions from the audience. First of all, if Governor Baker established the stay-at-home policy in late March when we were first aware of the pandemic's threat, why does Boston have such a colossal problem?
So there are two reasons why, despite the stay-at-home measures, we're still seeing the surge. And for the most part, not yet a real flattening of the curve. The first is just math. The incubation period of the virus is up to 14 days, meaning from the time you're exposed to somebody who has it, it can take as many as 14 days to develop the symptoms. So if a stay-at-home order is issued on a Monday, say, and a bunch of people were exposed the day before, even with perfect adherence to all of the rules, those people might still be getting sick as many as 13 days later after the stay-at-home order. And then, and I'll talk about this more later, but the disease tends to have two phases in those who get sick enough to go to the hospital. The more severe phase is generally week 2, could be 7, 8, 9 days into the illness. So now we're talking about around 22 days after the stay-at-home order. You're still going to be seeing people now going to the hospital. And that doesn't mean the distancing measures aren't working. And then the people who are really sick and who are going to end up dying, they don't do so right away when they arrive at the hospital. They might be receiving life-supporting therapies for a week or so. So those deaths are going to be seen maybe 30 days after the stay-at-home order, even if everyone is doing exactly what they're supposed to do. So although it may feel like we've been doing this for a long time, in some ways it's still too early to know if it's working. Now, the other reason we have a problem is this issue that everyone's probably heard about around test availability. When the disease was first recognized and the test first created, it could only be run at the CDC, and the capacity was very limited. We actually had to call the Massachusetts Department of Public Health every time we suspected a case of COVID. It wasn't called COVID back then, if you remember. It was called novel coronavirus, and ask for permission to send the test day and night. And the criteria were very strict. I had patients that I was seeing in January from Wuhan, China with cough, but no fever, or fever, but no cough. And I could not get approval to test them because they had to have fever and cough. Later, the geography of who we could test expanded. The Massachusetts State Lab obtained testing capacity, but there were still many patients that we felt we would have tested if we could have, and there were still criteria. It was actually astute doctors in California who pushed health authorities there to test a patient who met all the clinical criteria, but didn't have that appropriate travel history that was really still required. And that was what led to the realization that the virus was, in fact, spreading in the US. But by then, the cat was out of the bag, so to speak. And had we had a better understanding of how many people in Massachusetts were infected, we might have started those distancing measures earlier.
Do you think that there's any other reason, like that we have a particularly large number of travelers, for example, or anything like that?
All of those things come into play. Travelers, the Biogen conference, the density of the population, many things come into play, certainly.
And sorry, I'm springing this question on you. If you could turn back time and change one thing, what do you think it would be?
I think it would have to be, to have found a way to increase that testing capacity so that we could have expanded the criteria, tested people who appeared to have viral pneumonia, and figured out earlier whether we had the infection spreading in the community. We'll talk a little bit more in a little while about what you do when you are able to detect those cases and how you contain a pandemic.
Okay, so let's move. Next question. A listener asks, dry cough with no other symptoms, could it be the start of COVID-19?
The answer is yes. Let's talk about the symptoms of COVID-19. They can vary. You can have one or more of fever, chills, scratchy or sore throat, cough, shortness of breath, body aches. And strangely, and I say strange because we didn't hear about this until we started seeing patients in the US, loss of taste and smell is very characteristic of COVID-19 and can be quite profound and prolonged, and sometimes the only symptom. As I mentioned, the disease can have two phases. Many people will get better after about a week, but a small percentage will require hospitalization, only about 20%, often in the second week, with increasing shortness of breath and or chest tightness or other severe symptoms. Their x-rays show pneumonia throughout both lungs usually, and in severe cases, patients develop what we call a cytokine storm, this massive inflammation, which can lead to multi-organ failure and death. If you think you have COVID-19, you might be very tempted to run out and get a test. And although I just mentioned how important it would have been for us in the past to increase that testing capacity nationwide, to better understand the prevalence of the disease, to perhaps implement the social distancing measures earlier. At this point, anyone who has a respiratory illness can assume they have COVID-19 and should stay isolated at home and not necessarily seek testing unless you feel like you might need hospitalization, so worsening shortness of breath, chest pain, lightheadedness, confusion. On the CDC website is a self-checker. If you Google CDC COVID self-checker, I highly recommend it. You put in your symptoms and some info about yourself, age, your underlying medical problems, in fact, where you live, and it tells you where you should see, whether you should seek testing, whether you should go to the hospital, or whether you should stay home. And in most cases, the answer is stay home. At this time, testing is really important for patients who are admitted to the hospital and for those essential workers who are not able to stay at home and therefore are in continued close contact with others, like healthcare workers and grocery store workers. testing more widely will become important again when we're on the other side of the peak. And we'll talk about that a little bit more.
Yeah. So the only problem I see with this is that it must be so anxiety producing because those symptoms are so non-specific. And in fact, I heard that at Mass General, where they've tested anyone who has any symptoms that could possibly be suggestive of COVID-19, in 9 out of 10 cases, the tests are negative. So basically, you're just saying we all have to err way on the side of caution for this period.
Well, we're all staying at home anyway.
True.
And so if you have acute symptoms of respiratory illness, you should not go to the grocery store. But of course, it is allergy season, and many people are suffering from allergies. And if your symptoms are mild and sort of don't change over time, then that's probably less likely COVID-19. Either way, it's time to be very cautious about who you interact with.
Got it. Another question about symptoms. Why are some people completely asymptomatic but contagious while others will die from this disease? What other infectious diseases have this property?
Like so many things we don't know about this virus, we don't know exactly why some people have such mild illness or no illness while others get severely ill. We know that certain underlying medical conditions and older age play a role, and that's similar to what we see most years with the flu. There are a number of infectious diseases that can be detected in people without any symptoms and even spread to others. So that would include the Epstein-Barr virus, the virus that causes mono, herpes simplex. Virus can actually be transmitted from person to person without seeing any lesions. So it's not that unusual.
It still is just so mysterious, isn't it, to have that huge of a spectrum of severity.
It is.
Yeah. Okay. Next, do people with known comorbidities such as diabetes or asthma, so all those underlying conditions that are well controlled, still have a heightened risk of more severe complications?
Well, the data that are being collected in the US tell us what underlying medical problems people have who have been hospitalized with COVID-19 and who have died, but they don't tell us how well controlled those underlying diseases are. That being said, since the underlying mechanism probably relates to how much reserve you have in terms of lung function, in terms of being able to withstand lung inflammation, heart function, it's likely that having better control of those conditions would result in a better outcome for people who acquire COVID-19. But we know that some people with no medical conditions at all develop severe complications from COVID-19.
Yeah. So, okay. Next one about older people. The percentage of the dying who are over 60 is often reported, but not the mortality rate for the over 60 who are infected. How bad is it?
Yeah, so that is a good point and a good question. So the best numbers that we have to answer that question come from China. So I have them here to share. So if you look at the case fatality rate, so that's the number of deaths as a proportion of the number of confirmed cases. So take that with a grain of salt, because what you really love to know is the number of deaths as a proportion of people infected, which is different. If you are looking at the number of deaths as a proportion of the people who you know have it, that mortality rate is going to be falsely elevated to some extent. But the case fatality rate in the Chinese experience was 2.3%. Now, if you break that down by age, by decade, case fatality rate in the first decade, people less than 9 years of age was 0%. The case fatality rate in people aged 10 to 19 was 0.18%. And you can see where I'm going. 20 to 49 was 0.32, 50 to 59, 1.3. Now, when you get over 60, it really goes up pretty quickly. So 60 to 69%, the 60 to 69 years old, the case fatality rate was 3.6%, 70 to 79, 8%, and greater than 80 years, 14.8%.
But again, this is people who tested positive, as opposed to the denominator being everyone who actually probably had it.
Right. And so here they reported an overall case fatality rate of 2.3%. In South Korea, where they did more extensive testing, they reported a case fatality rate of under 1%.
Huh. Okay, good. Okay. How could Massachusetts residents use contact tracing apps enabled by Apple and Google's new protocol to slow the spread of COVID-19?
Okay, so let's talk about contact tracing. There are two stages in the response to a pandemic: containment and mitigation. During the containment phase, you're trying to detect every single case, isolate that person while they're contagious, find all of their contacts, that's people who are exposed to them, who could be incubating the virus or already sick, that's contact tracing, and quarantine them so they don't become contagious and infect anyone else. For this pandemic, though, we were hindered in our ability to contain the virus using contact tracing by the lack of widespread testing, as I mentioned. We weren't able to detect the cases in order to contain them. And we've now reached a stage where the number of new cases each day is so enormous that it would be prohibitive from a human resource standpoint to call them all on the phone and all their contacts. Also, I can tell you, because it's actually my team's job to do in-hospital contact tracing for all communicable diseases diagnosed in employees and patients. And for this infection, so many of the positive cases that we're detecting, especially in employees, are so mildly ill that they're going about their regular lives for days upon days before they even think to get tested. So the numbers of contacts are really large. So that's in part what brought us to this mitigation phase, which sort of took us out of the containment phase and puts us into the mitigation phase. Mitigation phase is where you use
Can
the
I pause you there for 1 second? Sorry. So that would suggest that even if we'd had enough tests, we still wouldn't have been able to really stop this because there would just be too much spread before anyone would even think about getting tested.
Well, if you can do it really early, if you can do it when there's one case, which, when there was one case at UMass Boston and he stayed at home for weeks and all his contacts did too. If you can do it effectively before it gets out of control, it can be done, even if each person has 100 contacts.
And even if they have super mild symptoms, if you can pinpoint them early enough, right?
Right. Well, that gets to the app. So mitigation phase is where you use the social distancing measures to minimize the damage, to flatten the curve, as they say. So you don't get such a large number of people sick all at once that the hospitals can't handle them and treat them and keep them alive. The hope is that when we're on the other side of the peak, we could actually get back to the containment phase. And so unique to Massachusetts is this initiative called the Contact Tracing Collaborative that's enlisted hundreds of people to perform contact tracing in an attempt to establish containment. And it may seem impossible now, but as the numbers hopefully decline again, it may become more realistic. And because calling someone who had a positive test will only tell you the names of the contacts that are known to them, they can only tell you who they were in contact with if they know that person. They can't tell you everyone that they were in contact with at the grocery store. That's where apps and other smartphone-based technology are being looked at as a way to more accurately determine who was in contact. They use a definition of 15 minutes within 6 feet right now with that sick person. And so the idea is that you would actually get a notification right on your phone that says something like, you've been exposed, quarantine for 14 days.
But again, it seems like given that this is a disease that spreads so insidiously and so broadly, I mean, so then you would have someone, let's say, who was walking around with it for a week, and then you would have to quarantine 1,000 people, stopping the spread, right?
And I can tell you that that's what we were finding when we were trying to do contact tracing in the hospital. The numbers were sometimes for one person were just enormous.
Yeah. And so, but I guess you could do that. But it's not even just that so we have the technology to do it, but practically,
right.
You get 1,000 people and then you have to quarantine 1,000 times 1,000 people. It just seems like we're right back at home.
Yes.
Everybody. It's a challenge. Okay.
Yes,
Next.
and that gets back to what you said about what 2021 and 2022 might still look like.
Yeah. Actually, I'd like to ask you a related question about that. This was a question that came from the absolutely wonderful longtime NPR reporter, Richard Knox, who pointed out that a lot of people are talking about the question of whether the solution or the partial solution might be to let most people out, but ask the highest risk people to remain in the stay-at-home mode. What do you think about that? So particularly older people.
Yeah, it's been suggested that because the older people are at the highest risk, maybe you just protect them and let the economy, open up. And I think the flaw there is, again, the math. Because, let me just go back to those numbers, we still have 0.18% dying at age 10 to 19. We still have 0.32% death rate at 20 to 49. And when those numbers get large, and think about the numbers that we're talking about in the United States right now, you don't want to just protect your old people. You need to protect everybody.
Although, could it become almost kind of comparable to flu, which we shut nothing down for every year?
Well, those were some of the arguments as they were considering whether to do this or not, whether to do social distancing or not. And, here we are seeing the healthcare system getting overwhelmed. So,
yeah, right. We just can't afford to do that. Okay. Next question. Someone who tests positive for this virus but has no symptoms, can this be explained? And does this mean this person is a carrier?
So this is another area of both uncertainty and anxiety. Carrier is a good word for this, but to what extent people with no symptoms actually transmit the infection is really not known. They aren't thought to play a major role. After all, the disease is transmitted in respiratory droplets that are propelled from your airway when you cough and sneeze, but they probably play some role, particularly in very close contact.
So there are carriers, and they may be people who never develop symptoms, right? Possibly.
Right. So positive tests in asymptomatic people with no symptoms, that probably fall into two categories: asymptomatic infection and pre-symptomatic infection. And many of them will go on to develop symptoms. If you happen to test someone who with no symptoms, and we have seen that here, some of them go on to develop those symptoms. You've caught them at the very early stage, but right. Some of them never do.
But so there is reason to believe that people who never develop symptoms could still spread COVID-19.
There is reason to believe, although they probably do not play a significant role in the pandemic.
Okay. Next, a listener writes, I've been told by 3 independent doctors that 20 to 25% of tests are false. I think that means false negatives, right? That like you seem to not have COVID-19, but in fact you do, as in my case. Why is this not being discussed more openly at a local and national level?
Well, I can tell you that the issue of false negative tests is certainly being discussed by healthcare professionals. We're very concerned about labeling somebody negative and having them go out and expose people. We're very concerned about labeling someone negative in the hospital and then taking care of them without PPE. The problem is this. In order to know what % of results of a certain type of test are false negative, you have to have something to compare it to that's better than the test you're evaluating. And to know how sensitive your new test is, you actually need to have something called a gold standard. But the test that we're using to detect the presence of the SARS-CoV-2 virus, the virus that causes COVID, which is a PCR-based test or polymerase chain reaction, is very, very sensitive. It actually detects minuscule quantities of virus in the sample. Nevertheless, we see a few things that make us wonder if we're experiencing these false negatives. So we see patients who have all the classic signs and symptoms of COVID, but the test is negative. We also see patients who test negative, and then we continue to have a high suspicion that they have COVID, and we repeat the test and they test positive. And that really makes us worry about the test. So there are a number of possible explanations for this. One is the technique with which the sample was taken. Now, I think most people have heard that the way that the sample is taken is a swab. The swab can be used in the nose, it can be used in the throat, or it can be used in the nasopharynx, which is to go into the nose and down into the throat through the nose. And so there's a possibility that the swab isn't done right, that it's a nasopharyngeal swab, but you only put it a little bit in the nose. You didn't get secretions, you didn't get cells. And that could be why the test is negative when it should be positive. Or it's possible that the patient just doesn't have COVID. There was some suggestion that as we were heading into this COVID season, we were actually starting to experience a pretty bad mycoplasma season. Mycoplasma is a bacteria that causes walking pneumonia. So, maybe these patients don't have COVID and it's not a false negative test. But basically, this should be added to the long list of things we're really trying hard to learn more about.
Well, is the bottom line that you would suggest to any patient who really seems like they have COVID and have tested negative that they ask for a repeat test?
I would not necessarily recommend that for someone who's an outpatient and at home. Because as I said, most people who are doing well at home should just stay home. But we have been repeating tests on patients in the hospital. It's important to know whether someone has it. It's important because we're desperately trying to conserve our personal protective equipment and not use it on patients who don't have it. It's important because we're desperately trying to get people into clinical trials so that they can get the benefit of experimental therapies. And the clinical trials sometimes require that they have a positive test. So for many reasons, we do need an accurate test, and we're very much trying to get more information about the accuracy.
And one other question about this are there reasonably good prospects of getting better tests, or are the mechanics of it just such that there's no way it's going to get much better?
Yeah, that's a good question. As I said, the PCR really is thought to be the best kind of test there is. Okay. So there are some additional efforts to make some more convenient tests, like a test where you might spit into a test tube as opposed to having to do a swab. But I'm not sure that any of them necessarily would be expected to be better or more sensitive.
Got it. Okay, next. There's talk of serological tests, which are tests for antibodies to the virus, being developed and they're blood tests as opposed to nasal tests, being developed for anti-COVID-19 antibodies. What are the implications for people who test negative? And I would add to this question, and what are the implications for people who test positive?
Yeah. So I'm both excited and a little bit afraid of the implications of serology or antibody tests. As you said, these are blood tests as opposed to the nasal or oral swabs that we do for COVID. And they tell you if you've had the disease sometime in the past. So they could be positive in people who had no symptoms or mild symptoms and didn't even think about the possibility that they had COVID, or somebody who knew they had COVID. They turn positive about 7 to 14 days into symptoms. And we think they'll stay positive for months to years, but because they're really just coming online now, we don't really know. We think that the presence of antibodies in the blood will hopefully confer at least some immunity to the virus. So someone with a positive test hopefully won't get COVID again, at least not for a little while, but we really don't know for sure. And we also aren't sure to what extent the common cold coronaviruses, the ones that aren't new, might cross-react with the test and give a false positive result. So there are a few potential uses for the antibody test. One would be to test frontline healthcare workers so that those who are positive can take comfort in the fact that they're at least somewhat protected while working. More controversial would be the question about whether you might actually use that information to configure your staffing in the hospital in the future, maybe targeting those healthcare workers that are potentially immune for COVID care, but perhaps once we know more about the immunity conferred by the antibodies. Even more controversial than that would be whether, in the case where PPE completely runs out, you'd use those healthcare workers exclusively. I'm not saying any of those things are ever going to come to pass, but those are things to consider as a potential utility of antibody testing. Now, another one would be to test widely, really on a large scale, to determine the population that has already had the disease, to calculate a true mortality rate, because as I said, right now we only know the proportion who die as a proportion of those who test positive, and then to determine how close our society is to what's called herd immunity. That's where enough of the population is immune that any newly infected person can't effectively transmit the virus to others because they only encounter immune people. That number is thought to be around 60 to 70%. And that data might be used in decisions to end social distancing measures. And similarly, but not exactly the same, even in the absence of herd immunity, you could use antibody testing to decide who gets to go back to work to slowly open up the economy.
It's the back to work license. Yeah. So, but there are still so many things we don't really know. We don't even know the extent to which testing positive for the antibodies confers immunity, right? So it's hard to, okay. So I would like to ask you for absolutely rank speculation, and we will label it as such. What is your gut best guess of, if we were to do serology testing on all Massachusetts residents right now, what % of us would test positive? And let us, again, I preface it by saying you have no idea. This is just guess, best guess.
Well, I've heard various guesses, but I'm going to say mine is somewhere in the 10 to 15% range.
Which actually coincides with, I think they're studying a village in Germany, and they found about 15% baseline rate right now. Yeah, so that's a very long way to go till herd immunity.
It is.
Okay, next question. As our understanding increases with new data and experience, can an accurate projection be made as to the duration of the pandemic and possible boomerang effect? I guess boomerang means it coming back after you lessen social distancing, right?
Exactly. I think the short answer is no regarding an accurate projection. Very smart people have built mathematical models designed to predict where we're headed. But models are based on assumptions, and there are a lot of assumptions still being made. We don't really know how well people are adhering to social distancing in their day-to-day lives. We don't really know what % of the population is sick now or has already recovered from the disease. We know from the influenza pandemic of 1918 that it is quite possible for cases to spike again after distancing measures are lifted. Right now, all eyes are on Wuhan as the canary in the coal mine, since they're just starting to open up.
Okay, well, we'll keep our eyes on them. Next question, will you please address COVID-19 being a zoonotic virus? So in other words, it comes from animals like H1N1.
Yeah, so the other two novel coronaviruses of the 21st century before this one, SARS and MERS, were also zoonotic like COVID-19. And that means that it jumped the species barrier. It jumped from animals to infect humans. And there are other zoonotic infections that you're likely familiar with, like salmonella, which you get from chickens and other animals that you eat or handle, and all of those insect-borne infections that we hate so much, like Lyme disease and malaria. It's likely that all three of the novel coronaviruses originated in bats and then entered an intermediate host animal and then humans. So SARS, we believe, got to humans through civets. MERS came from camels. And one theory is that COVID comes to us courtesy of the pangolin. There are several reasons why this is actually important. One is that MERS continues to percolate in the Middle East because of the fact that it persists in camels. And when cases are seen in humans, they often do have a history of camel contact. We've now seen that one or more tigers at a zoo have been infected, possibly due to the zoo worker. If the SARS-CoV-2 virus, the COVID-19 virus, begins circulating in animals with which humans have frequent contact, it will be very hard to end this pandemic with the traditional containment measures that we've already talked about. The other thing is, now that this has happened 3 times, 3 novel coronaviruses, and actually with increasing frequency, we need to make sure that we're doing what we need to do to prevent future events like this. Deforestation, for example, has been raised as something that brings human and animals closer together and leads to epidemics. I'm not saying that that's why camels or pangolins gave us coronaviruses, but it's one of the things that brings humans and animals closer together in settings that they might not have been in the past. So we need to think about all of those things that might create jumps across the species barrier and potential pandemics.
So I need to follow up. Did I hear, was the implication that it's possible? What do we know about dogs and cats?
Yeah. So it's interesting. The CDC very quietly put in their guidelines about the CDC guidelines for the public about what to do if you're sick. Said, stay home, stay in your own room, preferably your own bathroom. Don't come into contact with your pets. Stay away from your pets, have somebody else take care of them. And they never explained why they were saying that, but I think a lot of people thought that it meant that the CDC thought that the pet would transmit the COVID-19 virus on their fur to somebody else in your house. My assumption, and I talk to my CDC colleagues all the time, but I haven't asked them this, was always that because it jumped the species barrier, there was a fear that it could become carried in the respiratory tract or GI tract of animals or pets. I think that is likely to be true of various species of animals. And given that it was found in a tiger in the zoo, probably more likely cats, hopefully not dogs. There have been some studies have not been able to show it that it's carried by dogs. If it were to be carried by pests like rodents, there could be a lot more spread. So yet another thing we need a lot more research on. So
at this point, aside from the tiger and the bats, we don't actually know which animals carry it, though.
No, there's just some early research on that.
Okay, next, this is a big one. What do we know about the aerosolization of the virus, and would its ability to remain airborne be different outside than indoors?
Yeah, so aerosolization is something I spend a lot of time thinking about and talking about here in the hospital, partly because our hospital rooms and our PPE supply do not fully support our ability to deal with a classically airborne virus on the scale at which we're seeing this pandemic. But luckily, the virus is not airborne in the sense that other viruses like measles are. And we know that because of a lot of things, epidemiologic things, like the household attack rate, for example. 10% of household contacts of people with COVID develop disease versus more than 90% with measles, a truly airborne disease.
So wait, let's back up on that. So in other words, if you have someone with COVID-19 in your household, you only have a 10% chance of catching it from them.
Right, because it's the droplets that only goes approximately 6 feet in most conditions, and the contact, as opposed to it traveling through the air. Measles can infect somebody on the other side of the building. So it's very different. We also know from well-characterized outbreaks like that on the Diamond Princess cruise ship, where they even tested asymptomatic individuals. So we even have that information. 17% attack rate, or percent of people that were secondarily infected, which is way lower than you would expect for an airborne virus in a setting where there's one air handling system.
Yeah.
Is it possible that the virus sometimes travels farther than 6 feet? Sure, sometimes. But that's not the primary mode of spread. And outdoors is the best place to be, or indoors with the windows open. The virus will dissipate.
Dissipate, or does temperature matter, do we think?
Temperature and humidity likely play a role in the virus's ability to survive. We have some questions that are coming through. I'm just going to take a quick look.
You want to use them? Okay. Let's see. How about, here's this one. Where are new cases coming from other than elderly living facilities and nursing homes since we've been social distancing? So you explained some of that about the timing, but what would you say?
Yeah. I think that they are likely coming from people who are continuing to work, essential workers, and people who maybe are not following social distancing. I mean, we know that there have been quite a few infections in Boston MBTA, Boston area MBTA workers. We know that situations where it's difficult to stay 6 feet apart, like public transportation, are going to be an area of spread. We know that even the grocery store, despite the fact that you have to do it, is going to be an area of spread. We are not going to be able to fully fully prevent all new cases of this virus unless we have a full military lockdown, and we don't want that.
Yeah, wow. Okay, vaccine question. Could vaccines for MERS, SARS, and COVID-19 provide some protection against future novel coronaviruses so that the effects of future viruses are blunted?
The answer is we just don't know. We don't even know if a vaccine for COVID-19 will last beyond a season or a few months. There's so much we don't know about this virus. Experts say that the immunity can be pretty fragile, actually, and can be pretty fleeting with coronaviruses. So, that's why I said earlier, I don't want people to have, put all their hopes in a vaccine as the solution. It just might not be the case.
Yeah. I mean, are you thinking at this point that there's kind of no way, there's likely to be no way around just waves of people getting it, but trying to keep the curve flat enough so we don't overwhelm the hospitals, but we're just basically probably all going to have to get it until we reach herd immunity?
I think that when social distancing measures were put in place, the rationale was never stay home so you never get it.
Right.
The rationale was stay home so everyone doesn't get it all at once.
Yeah. And of course, a treatment could make a huge difference. So let's do this question.
Yes.
Have any Massachusetts hospitals started using convalescent plasma for their patients? If so, what are the preliminary results or early indications?
Yeah, I believe that at least one Massachusetts hospital is using convalescent plasma. And just so people know what that is, that means taking blood and separating out the plasma from people who have had the virus and recovered, and then using that plasma, which is rich with immune factors, including antibodies, giving it to somebody who's suffering from the virus to help them get over the virus. I'm going to just say this as a blanket statement about all the treatments. It is way too early to make any conclusions about whether it works, because we just know that some people get better on their own. And so you can give people in the hospital a treatment and they will get better. And you can give them a placebo and they will get better. And you can give them the treatment and they will get worse. And you can give them a placebo and they will get worse. And we cannot say yet whether any of the signals that we're seeing are anything to hang our hat on, because you can only say that in the context of a clinical trial that is randomized into treatment and placebo, or treatment and standard of care, where you look, when it's all over, at a large enough number of people and you see if there's a statistically significant difference.
Right, so that's months away any way you look at it. I have one little side question. Is there any reason to think, given what we know about other illnesses, that if you have worse symptoms, a worse case, you're likelier to develop greater immunity afterward, or are they unconnected?
That's been raised as a question. It is not known. Yeah, so if you're one of those asymptomatic or mildly symptomatic, will you have enough immunity to avoid getting the virus again? I hope so. But
Okay. We have time for just a couple more questions. This has been a very complex and difficult issue. When push comes to shove to prioritize who gets a ventilator, are there protections in place to keep it egalitarian and based solely on a medical basis?
Yeah. Luckily, I don't have to make those decisions. And I'm not involved in those protocols, but I can tell you that my colleagues in critical care have spent a lot of time over the last few months coming and working with our medical ethicists to come up with the best possible strategies to deal with situations like that.
Mm-hmm. Yeah, I'm glad you don't have to deal with it. It's a hard one. Okay, last question. What do you recommend for families who are delivering babies?
Yeah, it's so hard because of the visitor policies, the no visitors, and the fear that a new mom will get COVID-19 and be separated from her baby while she recovers. There are so many things. Here at Tufts Medical Center, we do allow a support person in the delivery room. It is recommended that if a mom has COVID-19 at the time of delivery, that we test the baby. It is recommended that the baby be separated from the mom so that the mom doesn't give the baby COVID-19, which is so sad. And then, it's definitely a source of great anxiety for our expecting moms. And it's tough. It's really tough. Now, the good news is that we hope that by feeding the baby breast milk, that will be protective, actually, of the baby getting COVID-19 in the home. We're trying to do everything we can. We're giving all moms at the time of discharge cloth masks that volunteers have been bringing to the hospital, because we know that, if the moms do get sick, it's so hard to find disposable masks out there. So we're providing them with that and lots of instructions on what to do if they were to get ill, but it's a hard time for expectant moms.
Is it thought that COVID-19 is transmitted in the womb?
No, it is not thought.
No. Okay. So then it really is. But the mother has antibodies in her breast milk that could help the baby be resistant to it?
That could help prevent them from getting a severe case. Yeah.
Uh-huh. Interesting. Great. Well, we have to wrap this up. Dr. Doron, you are a gifted explainer. Thank you so much for doing this. Thank you also to the CitySpace team who made this event possible, and to all of you at home, really at home, who came, who joined together to learn together and to look forward together. Our next virtual town hall will be next Tuesday, same time, same place. We'll be speaking with Dr. Kevin Tabb, the head of Beth Israel Lahey Health. We're very optimistically planning for the theme. I hope it's not too optimistic, for the theme to be after the surge. I mean, we're clearly in the surge right now. Let's hope that by then we can start looking forward after the surge, the challenges that come next for the healthcare system and for all of us and in the pandemic. You can register at wbur.org/events. Dr. Doron, any final words? Maybe something uplifting to send us out?
Be strong, everyone. Stay healthy.
Yeah, actually the best sign off I've gotten recently from an email was from a neurologist today who said, wishing you health, safety, and sanity, which need all three. So take care. And I'm sorry, I had some final words I was supposed to say to let our engineers know that we were done. I'm trying to remember what those were. Niall, if you're out there, you can go ahead and end this session. To everybody, thank you for coming. We hope you can come back next week. Thank you.